Welcome to UMCC Medical Consultant Connectors. We're glad you could join us today. Here at UMCC, your health truly matters to us. We believe knowledge is a powerful tool for health, to help you make the best decisions for well-being. Today, we focus on an important medication, intravenous dopamine, a cornerstone of critical care medicine. We will unlock the science behind dopamine. It helps stabilize critically ill patients while doctors treat the underlying cause. Given by IV, it acts rapidly and requires ICU monitoring. Let's begin with where and why it's used. Dopamine is reserved for life-threatening situations such as shock. Your safety is our priority. Subtitles available for every line. The primary indications are specific and reserved for emergencies. First, cardiogenic shock, when the heart cannot pump sufficiently after a major heart attack. Second, septic shock requiring vasopressor support. It is also used for symptomatic bradycardia when pacing or fluids are inadequate, and for hypotension that does not respond to fluid resuscitation. Its role is to buy time, stabilize perfusion while teams address the root cause. Note, this is the intravenous medication, distinct from dopamine as a brain neurotransmitter. While chemically the same, their clinical contexts are different. Next, we'll examine how the drug behaves in the body, pharmacokinetics and pharmacodynamics. Pharmacokinetics describes the drug's journey through the body. When given IV, dopamine enters the bloodstream and acts quickly, often within 5 minutes. It has a very short half-life, about 2 minutes. Dopamine is rapidly metabolized and cleared, so it requires continuous infusion to maintain effect. Metabolism occurs mainly in the liver, kidneys, and plasma by MAO and COMT enzymes. Breakdown products are excreted in the urine. Pharmacodynamics. Effects depend on the dose. At low doses, dopamine primarily stimulates renal dopamine receptors, increasing renal blood flow. This may support urine output in select situations. At moderate doses, dopamine stimulates beta-1 adrenergic receptors in the heart. This increases the force of cardiac contraction and cardiac output. Clinicians seek this effect in cardiogenic shock. At higher doses, alpha-1 adrenergic receptors are stimulated. Alpha-1 activation causes vasoconstriction, increasing systemic blood pressure. This ensures perfusion of brain, heart, and kidneys when pressures are low. Because effects are dose-dependent and short-lived, precise titration is possible. Continuous monitoring in the ICU allows rapid adjustment and stopping if needed. Rapid onset, short half-life, rapid clearance. In short, lower doses favor renal perfusion, moderate doses boost heart contractility, higher doses increase vascular tone. This versatility makes dopamine useful but also demands vigilance. Next, important drug interactions and contraindications to remember. Clinicians must watch for significant drug-drug interactions. MAO inhibitors can block dopamine breakdown, causing exaggerated, prolonged effects and severe hypertension. If MAOI use in the past 2-3 weeks, start at a substantially reduced dose, possibly 1/10. Tricyclic antidepressants can increase dopamine's cardiovascular effects. This may raise heart rate and blood pressure excessively. Halogenated anesthetics can sensitize the heart to arrhythmias with dopamine. Continuous EKG monitoring is essential. Diuretics may reduce plasma volume and blunt dopamine's pressor effect. Phenytoin has been reported to cause sudden hypertension and bradycardia when combined with dopamine. When combinations are unavoidable, clinicians must be prepared to adjust doses or choose alternatives. Contraindications include pheochromocytoma. Dopamine can trigger hypertensive crisis in these patients. Also contraindicated, uncorrected tachyarrhythmias and ventricular fibrillation. Correct these rhythms first. Extreme caution, continuous monitoring, and readiness to treat arrhythmias are non-negotiable. Safety in pregnancy is paramount. Dopamine is reserved for life-threatening maternal emergencies when maternal benefit outweighs fetal risk. It is classified as pregnancy category C, limited data in humans. Dopamine can reduce uterine blood flow, potentially compromising fetal oxygen delivery. Use is a careful balancing act in critical situations. Common adverse effects include ectopic heartbeats, tachycardia, angina or chest pain, nausea and vomiting, headache and anxiety. Severe effects include hypertensive crises at high doses and extravasation injuries at the IV site. Extravasation can cause tissue ischemia and necrosis due to potent vasoconstriction. Immediate injection of phentolamine into the affected area is required to restore blood flow. Patients with atherosclerosis, Raynaud's, Berger's, or peripheral vascular disease are at higher risk for ischemia. Close monitoring of skin color and temperature is essential. Reduce or stop the infusion if circulation worsens. Vigilant monitoring is the key to safe dopamine use. We covered indications, pharmacokinetics, pharmacodynamics, interactions, contraindications, pregnancy guidance, and adverse effects. Thank you for joining us. At UMCC Medical Consultant Connectors, your health matters to us. Stay safe and be well. We look forward to connecting with you again soon.